Hello, everyone, and welcome to the first session of Mini Medical School, the Heart of Health. My name is Jeremy Vant Hoff. I am an assistant professor of medicine in the cardiovascular division at the University of Minnesota Medical School. We are excited to have you here today, and we look forward to guiding you in the heart of health. The first topic in the series is lifestyle, equity, and prevention in heart health. We will begin with a moderated discussion, followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box. This can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Now, today, we have the privilege of speaking with a panel of leading experts in cardiovascular care at the University of Minnesota. They will discuss the leading research behind exercise and diet, strategies for reducing heart disease risks, and efforts to promote heart health equity. I would like to introduce our first panelist, Daniel Craighead. Daniel is an assistant professor in exercise physiology in the School of Kinesiology. His research revolves around understanding why the cardiovascular system becomes dysfunctional with aging and disease, and testing potential therapies for improving cardiovascular function. Daniel is particularly interested in novel forms of physical activity that may overcome barriers to regular exercise. Daniel, we are excited to hear about your discussion on exercise and cardiovascular health. Please go ahead and get us started.
Much for that introduction, and thanks for having me today. I'm really excited to speak with all of you. Sort of from the get-go, just want to let you know that I have nothing to disclose related to this presentation. And kind of to start with, as a background of what I'm going to talk to you about today, or sort of an outline, I'm going to start by telling you what do I mean when I talk about cardiovascular disease or cardiovascular disease risk. Then we'll go over what the current guidelines for exercise are and talk about how meeting these exercise guidelines can impact our cardiovascular disease risk. We'll then talk a little bit about the how this happens before talking about how good we are at actually adhering to guidelines for aerobic exercise, and then what are maybe some alternative types of exercise that could be helpful for lowering our cardiovascular disease risk. So let's jump into that. When I talk about cardiovascular diseases, I'm talking about things like coronary heart disease, heart failure, cerebrovascular disease, so disease of the blood vessels in the brain, peripheral artery disease or deep vein thrombosis, so things impacting arteries kind of in our periphery or in our limbs. And these chronic conditions can lead to acute events like heart attacks or strokes that lead to morbidity and mortality. So cardiovascular diseases like these are actually the leading cause of death among adults in the United States. This graph on your screen shows the leading causes of death in the US, and cardiovascular diseases, highlighted in red, contribute to over 30% of all deaths in the US, and this beats out other common conditions such as cancer, respiratory conditions, accidents, etc. So cardiovascular disease is really a significant public health condition. Cardiovascular diseases also really are a condition of aging. This new graph shows you the percent of the population in the US diagnosed with a cardiovascular disease, binned into different age groups along the bottom. So people aged 20 to 39, almost none of them have cardiovascular diseases. The prevalence is about 1%. But as we get older, the prevalence of cardiovascular diseases grows significantly, such that the prevalence at 60 years of age and older is really high. Now, the demographics of our nation are changing such that we're getting a significant number of more midlife and older adults, meaning we can expect an increased burden of cardiovascular diseases due to our aging population unless we're able to do something to lower our disease risk. So that's where exercise comes into play. So let's talk a little bit about current exercise guidelines and then how meeting these guidelines can impact our risk for cardiovascular diseases. To start off, the first part of our current exercise guidelines are to move more and sit less. So some physical activity is better than none. Going from being totally inactive to just a little bit active can have really profound impacts on your health. So even if you can't meet the full guidelines that I'm about to tell you about next, just being active at all is critical for your health and will help you. Now, current guidelines call for trying to meet targets of 150 to 300 minutes per week of aerobic exercise. And that's things like walking, running, cycling, and we'll go over some specific examples of this on the next slide. But the goal is to perform 150 to 300 minutes of these types of exercise, which comes out to about 30 minutes to an hour of aerobic exercise most days per week. Current exercise guidelines also call for strength training. So doing strength training, which is something that targets all your major muscle groups, could be lifting weights, doing push-ups, other things like that, 2 days per week. So those are the goals that we're trying to hit. Now, what are some specific examples of how you can be active to actually meet these goals? So for aerobic exercise, you can meet that through things like brisk walking, recreational swimming, power yoga, or biking on level terrain. And those are all sort of moderate intensity activities that get your heart rate and your breathing rate up, but aren't too intense. If you want to save a little time, you can perform vigorous intensity aerobic exercise, and then guidelines only call for performing at least 75 minutes per week of these type of activities. And that would be running, jumping rope, singles tennis, or taking a kickboxing class. So things that are a much higher intensity are able to make you meet the guidelines in about half the time. And then for strength training, it could be things like lifting weights, doing body weight calisthenics, even activities of daily living like carrying heavy loads and vigorous gardening that involves a lot of pushing, pulling, digging would count as strength training as well. So these are the types of things you can do to meet our current exercise guidelines. Now, the reason the guidelines are the way they are is because they've been shown to help reduce our cardiovascular disease risk. So this schematic shows cardiovascular disease risk on the y-axis and exercise in how many minutes per week you exercise on the bottom on the x-axis. So in the top left, we have people who are minimally or not active at all, and they have the highest risk for cardiovascular disease. Then with sort of any increasing activity, we see this real immediate drop in our disease risk, which goes back to how I said any activity is better than none. With increasing exercise, we start to see sort of a slowing down of the decline in risk and then almost a plateau. Now, meeting exercise guidelines kind of gets you into this area in the middle where you've gotten most of the benefit by exercising at this volume. Going further may have some additional benefits, but not a ton. It's kind of diminishing returns. So if you meet the guidelines I just laid out for aerobic exercise and strength training, you will reduce your cardiovascular disease risk by maybe 40 or 50%. And if you look at it, on a population level, that would really improve our health as a country and lower the burden of cardiovascular diseases that we face. So let's talk a little bit about how exercise reduces our cardiovascular disease risk. There are some traditional cardiovascular disease risk factors that exercise is really good at improving. So that's things like blood sugar and cholesterol. High blood sugar and high cholesterol can increase our risk for cardiovascular disease, and being active improves those measures and reduces our risk. There's also blood pressure. So high blood pressure can damage your blood vessels and your organs and puts a lot of strain on your heart. But exercise lowers our blood pressure, and that improves our health and reduces our disease risk. And then exercise is important for healthy weight maintenance and maintaining a good body composition. So exercise is really critical for that cardiovascular disease risk factor as well. Something that is maybe less discussed, but equally as important as these other traditional risk factors, is the direct impact that exercise has on our blood vessel health and function. And that's what I'm going to highlight a little bit next. So what do we mean when we talk about the health of our blood vessels? I really talk about two kind of separate ways we look at how well our blood vessels work or how healthy they are. Those ways are arterial stiffness and endothelial function. So arterial stiffness is kind of just what it sounds like. It's how stiff your arteries are. We want nice and compliant arteries, which means that they're able to expand and then recoil back to their initial shape. However, arteries can become stiffer, meaning they're not able to change their diameter well, and that can have some negative health consequences. Endothelial cells are the cells that form the inner lining of our blood vessels, and they're really important for producing chemicals that prevent plaque buildup in our arteries, so preventing the progression of cardiovascular disease. If our endothelial cells aren't working that well, then cardiovascular disease can start to develop. So with increasing age and in some patient populations, so groups like patients with chronic kidney disease, for example, we see our blood vessel health change in negative ways. So our arteries get stiffer and our endothelial cells stop working as well, and both of those can increase our risk for cardiovascular diseases. But thankfully, meeting exercise guidelines reverses those changes. It makes our arteries less stiff, improves the health of our endothelial cells. So a large way in which exercise is good for our cardiovasculature is by directly impacting the blood vessels in these ways. So hopefully that's convinced you that we should all strive to meet current exercise guidelines and that we know exercise is good for us and can be healthy, particularly when talking about our cardiovascular system. I want you just to take a second, though, and try to guess how many people in the US you think meet guidelines for both aerobic exercise and strength training. The current number of people we have actually adhering in the US is only 23%, so less than a quarter of all people meet current exercise guidelines. Now, there are some people who may just adhere to aerobic exercise guidelines, so that's another 23% of people meet those guidelines but not strength training. And then 7% of people meet strength training guidelines, but not aerobic exercise. But when you add all those numbers up, that means there's still 47% of adults in the US who are not meeting any of the physical activity guidelines and not getting those cardiovascular health benefits. Now, there are a lot of very reasonable, reasons why someone might be inactive. If you have an injury or an orthopedic limitation that keeps you from doing these types of activity, that could be one. There's also barriers such as time availability, so not having the time to do 30 to 60 minutes of aerobic exercise every day, not having the financial ability to buy expensive exercise equipment or purchase gym memberships, or maybe environment or transportation related barriers where you don't live in an area with a nice outdoor environment for exercise and don't have the capabilities to travel to an area where exercise would be more conducive. So those are all very real barriers that people have to overcome and contribute to this sort of suboptimal rate of adherence that we have to exercise. So one of my goals is to try to move people from this inactive side over to meeting exercise guidelines by overcoming these barriers to adherence. So I'm going to finish my time by telling you about some ways that maybe we can get some of the cardiovascular health benefits of exercise without fully meeting those guidelines that I've told you about. I'm going to tell you about 4 different things. One is the weekend warrior exercise strategy. Another is isometric exercise, then heat therapy, and then finally inspiratory muscle strength training. Before I get into any of these, I just want to highlight that I'm not a medical doctor and I'm certainly not your medical doctor. So before you try any of the things I'm going to tell you about, I recommend that you consult with your primary care physician. So with that, let's jump into the weekend warrior style. So a lot of people face time availability related barriers due to work during the work week, but then have more time for exercise available on the weekend. And that pattern then would allow them to be physically active on Sunday and Saturday, even though they have to be generally inactive during the weekdays. For a long time, we thought that this sort of physical activity pattern of being active for 2 days and then relatively sedentary for 5 wouldn't be enough to, or wouldn't be able to get us those heart health benefits that exercise can. However, information is coming out showing that if you are sufficiently active on the weekends, you can still get a lot of heart health benefits, even if you're inactive on the weekdays. So we now think that in people who perform at least 115 minutes of exercise on the weekend can lower their cardiovascular disease risk by a little over 30%, which is getting in that same realm as actually meeting our exercise guidelines and being active almost every day. The trick is you have to be pretty active on the weekend. So 115 minutes on the weekend is a pretty fair amount. So it's not enough to just go do a tiny bit of exercise these days. You have to really load it up. But if you have time on the weekend or some other specific days of the week, if you're very active those days, you can still see a lot of heart health benefits from physical activity. Next, I'm going to tell you about isometric exercise. So isometric exercise is muscle contraction with no movement. Examples of that would be things like wall sits or planks. There's a lot of muscle tension as you're trying to hold a position, and it takes a lot of effort, but the body isn't moving in any way. It's staying static. Isometric exercise has been used for a long time for muscle strength training, but we're just now starting to understand that it has cardiovascular health benefits as well. So data has recently come out showing that doing isometric exercise like wall sits lowers blood pressure more than aerobic exercise or that traditional dynamic resistance exercise where you're moving through a range of motion. So isometric exercise will lower systolic blood pressure, that top number in a reading, by about 8 millimeters mercury, and it will lower diastolic blood pressure, or that bottom number in a reading, by about 4 millimeters mercury. And that's 1.5 to 2 times higher than other types of exercise are capable of lowering blood pressure. So isometric exercise may be a really effective type of exercise for that key cardiovascular disease risk factor of blood pressure. Another benefit of isometric exercise is it can be done and you can get these blood pressure benefits in only a few minutes per day. So about 8 minutes a day of isometric exercise will lead to these robust reductions in blood pressure. The main caveat I have at this time is we don't know the impact that isometric exercise has on those other cardiovascular risk factors. So we don't know if it will help with cholesterol, for example, or if it will improve the health of our blood vessels. But it seems to have a very robust effect on blood pressure, and in that way can be really good for someone who's strapped for time. Next up is heat therapy, and this comes from epidemiological data out of Finland where people regularly do sauna bathing multiple times a week. So sauna bathing, you're exposing yourself to a very hot environment. And what they've seen in Finland is that the more you sauna bathe, the lower risk you have for cardiovascular diseases. So people who sauna bathe 2 to 3 times a week lower their cardiovascular disease risk by about 30%. And those who sauna bathe 4 to 7 times a week lower their cardiovascular disease risk by an enormous 70%. So that's a huge decreased risk for cardiovascular diseases. The caveat I have for this one is that correlation does not necessarily equal causation. So in Finland, sauna bathing is really part of the culture. But if you're able to go sauna bathe 7 times a week, that means you have the time and financial ability to do that, which is, having more financial resources is also associated with having lower cardiovascular disease risk. Sauna bathing is also a very social activity, and social connectedness is a way to improve our health. So it might not just be the regularly heating in a sauna, there could be other aspects. However, heat exposure does mimic aerobic exercise in some key ways. So if you get in the sauna or you get in a hot tub and your core body temperature gets warmer, your body will respond by having an increase in heart rate and an increase in blood flow through your blood vessels, very similar to if you were out for a walk or a run. So because our bodies do react similarly, we think that regular heat exposure in a hot tub or sauna could be a way to improve cardiovascular health without actually directly exercising. So if you have an injury or something else that keeps you from performing traditional types of exercise, regular heat exposure in a sauna or hot tub could be a way to improve heart health. And finally, I'm going to close by telling you about something called inspiratory muscle strength training, or IMST. IMST involves inhaling through a handheld device that provides resistance when you breathe in. Exhaling, there's no resistance. In this way, it's like strength training, but just for the muscles that you use to inhale. IMST is also very time efficient. So when people do this practice, they do 30 resisted inspirations per day, which takes 5 to 10 minutes per day to do. It's also done with this portable and affordable handheld device, so it can be done at home, even if you don't have a lot of other exercise equipment or the ability to travel. And what we've seen is that people who do IMST for this 30 breaths a day for about 6 weeks, their blood pressure goes down, their systolic blood pressure by 9 millimeters mercury and diastolic blood pressure by 4 millimeters mercury. So as a reminder, that's more than what we see with other conventional types of exercise. And again, that's accomplished with a little over 5 minutes a day, so very time efficient. We've also seen benefits from this type of breathing exercise on the health of those endothelial cells, so the cells that form the inner lining of our blood vessels. So it looks like IMST may be a way to improve some of these measures of cardiovascular health. Though kind of like some of the other ones we've talked about, we don't know what it does for cholesterol or blood sugar, and it probably won't help with weight maintenance, but does have some real specific health benefits for your cardiovasculature. So I'm just going to wrap up by reminding you that cardiovascular disease is the leading cause of death in the United States. If we meet aerobic exercise guidelines for 150 to 300 minutes per week of aerobic exercise and strength training 2 times a week, we can really dramatically reduce our cardiovascular disease risk. But even if you can't meet those guidelines, something is better than nothing, and being any sort of active will help improve your health and reduce your disease risk. And if you want to be more active, but there's barriers to adherence, there are alternative ways that are emerging that we think might be able to lower our cardiovascular disease risk. So hopefully these can get over some of those barriers to adherence we have as a nation and improve our heart health. So I'd just like to quickly acknowledge my funding sources and looking forward to the Q&A at the end of this session. Thanks everyone for listening.
Okay, thank you, Daniel. That was great. As a reminder to everyone, please continue to submit your questions using the Q&A box. Our panelists will answer them after all the presentations are complete. So next, I'd like to introduce Lisa Harnick. Lisa is a professor in the Division of Epidemiology and Community Health at the School of Public Health. She is a public health nutrition expert whose research focuses on improving the scientific evidence guiding nutrition policies, programs, and practices. She directs the university's Nutrition Coordinating Center, which provides widely used dietary assessment tools, supporting research at over 100 institutions, including major research universities and government agencies such as the NIH and NASA. Lisa, can you please discuss how what we eat affects our cardiovascular health?
Sure, great to be here, and I'm a weekend warrior, so I'm feeling pretty good about my physical activity might be okay. Might not feel so bad about missing some weekdays. So yeah, I'm going to talk with you about eating for heart health, and what I'll do is talk about current dietary guidance for heart disease prevention, and then talk about what is not included in current dietary guidance and why. And then I'll wrap up by sharing some public health success stories around public policy changes that are supporting good nutrition for heart health. So starting with what's recommended, I'm going to be sharing recommendations from the dietary guidelines for Americans, which you've probably heard of. These are put together by the United States Department of Agriculture and the Department of Health and Human Services. Every 5 years, the scientific evidence base is reviewed to update recommendations for how we should eat for prevention of heart disease, cancer, and other diseases, along with meeting our nutrient requirements to prevent deficiencies. And there's a panel of experts that are convened to review the scientific evidence and create a scientific report that is passed on to USDA and the Department of Health and Human Services for coming up with the actual guidelines that you see and that you interface with as the public. And so let me just go through the key recommendations in the dietary guidelines. Maybe you've seen this My Plate graphic that really in a snapshot shows us how we should be eating for prevention of heart disease and other chronic diseases. And with regard to fruits, at least half of your fruits should be whole fruits. So, it can't all be fruit juices. And with regard to vegetables, there's a focus on dark green, red, and orange vegetables, along with legumes and beans. So choosing colorful vegetables is the way to go. For grains, choosing at least half of the grains being whole grains, so things like whole grain bread, um, whole grain cereals, brown rice, popcorn's a whole grain. And then for dairy, choosing low-fat dairy, milk, and yogurt. If you choose plant-based milks, soy milk that's kept fortified with calcium and vitamin D is recommended as an alternative to cow's milk. And then finally, for protein, the recommendation is to focus on lean meats, eggs, nuts, seeds, legumes, and beans as sources of protein. The dietary guidelines also include the recommendation to limit your sodium intake to no more than 2,300 milligrams per day. And this is largely related to heart disease prevention of high blood pressure that leads to heart disease. We're also to limit our intake of sugary foods and limit saturated fat intake and choose unsaturated fats as well. And this, again, is directly related to heart disease prevention. And this graphic from the American Heart Association, I really like it, how it, in pictures depicts that what you should be going for is those vegetable oils and foods rich in unsaturated fats like avocado or salmon, nuts, seeds, but then limit fatty meats, dairy that's high-fat dairy, and then also the tropical oils, coconut oil and palm oil are actually rich in saturated fats. There's a recommendation around alcohol, which does relate to heart disease as well, and it's a little complicated. It says that if you currently drink alcohol, you should drink in moderation, which is for men, no more than 2 drinks a day, and for women, it's no more than 1 drink a day. There's evidence that shows that moderate alcohol consumption can lower blood pressure relative to not drinking alcohol or drinking a high amount of alcohol. So that's where this moderate level comes in, but drinking too much has an adverse effect on blood pressure. And also there's increased risk for certain cancers with alcohol consumption. Now you might wonder, well, how come if I don't currently drink, I'm advised to not start drinking? And that really ties in with the fact that if you're predisposed to alcoholism, you don't want to be recommending to people that they begin drinking. And if they're predisposed to that, to go on to have alcoholism, which has a whole set of adverse consequences. So a little confusing, but that's why it's not sort of cut and dried. It has a lot of effects on health, both good and bad. Now, the American Heart Association has dietary recommendations as well, and they're pretty much overlap nearly completely with those that are in the dietary guidelines for Americans. If you're looking for information about how to eat for heart health, I think that the American Heart Association, checking out their website or following them on social media is a great way to keep up on that, as well as other lifestyle things you can do for heart disease prevention. So that's just a plug for the American Heart Association. They have a lot of consumer-oriented information on their website and social media feeds. Now, what is not in the dietary guidelines or not in the recommendations that you think, well, why isn't this recommended? And let's start with dark chocolate, which I love, but you probably just saw that was not mentioned as something that you should be eating for prevention of heart disease or other chronic diseases. And that's because although there's been research on the heart effects on heart health of dark chocolate, the findings have been really mixed. It's not clear there's benefit. And we also know that dark chocolate is high in saturated fat and added sugars. So it is not recommended for those reasons. Mixed evidence, and also, it's high in these things that we tell people to limit for heart health. The thing in dark chocolate that might confer the protection is something called flavonoids. And dark chocolate is not the only place you can get flavonoids. There's a lot of fruits that are rich in flavonoids, and they are recommended in the dietary guidelines for Americans and the American Heart Association recommendations. So if you want to, get flavonoids in your diet, choose flavonoid-rich fruits and vegetables, and actually green tea is also high in flavonoids. So if you drink that, you're getting it there. So So another thing that's not in the guidelines is there is no recommendation to avoid seed oils. And you've maybe heard in the news a push to eliminate seed oils from your diet. And seed oils are things like corn oil and uh, sunflower oil. And really, a lot of the oils in the vegetable aisle are considered seed oils. And I like this American Heart Association article title. It kind of nicely conveys the scientific evidence around seed oils, which is there's no reason to avoid seed oils and plenty of reasons to eat them. Seed oils are rich in those unsaturated fatty acids and low in saturated fats, which is recommended for heart disease prevention. And if you want to know sort of why some people are saying that seed oil should be avoided, I don't have time to go into it today, but I suggest that you might consider following unbiased science. They have a website and they also have social media feeds. And for every sort of nutrition related thing that comes out that's where there's a lot of misinformation or confusion around it, they tend to try and then really explain the rationale for why some people think it's harmful and why it, really probably isn't, or based on the current science, we don't think it's bad. And so I'd consider following them or checking out their website for information on this. They may at first glance seem like they're purveyors of misinformation because they use some of the same tactics that the misinformation purveyors use. They use, really catchy, grabby graphics. And this is an example of one of their Instagram posts. They have a graphic artist on staff who kind of, if you're competing with flashy things, it's kind of fight fire with fire, use the same kind of imaging. And they also really focus on conveying information in a way that everyday language that anyone can understand, which we scientists are not always good at doing. So I appreciate that they're translating the science into something that hopefully everyone can understand. Now, there was no recommendation to take a multivitamin. And that's because there's actually a lot of, rigorous randomized trials that have been done to evaluate whether a multivitamin might help prevent heart disease or cancer. And there is not evidence that it's beneficial for heart disease prevention or cancer. There doesn't appear to be harm. So if you're taking a multivitamin, it's fine. But you could also think about whether there's a way to use your time and money that might be, more beneficial. So that's sort of multivitamins. And then kind of another big thing that's not in the recommendations is you are not told to avoid or ditch ultra-processed foods. And again, this is something that's really in the news, right? And so you might wonder, why not? Well, one reason is that it turns out that the research is showing that it might be that some ultra-processed foods are probably not bad for you. They, in fact, may be good for you. And so here's an example of some of the foods that are ultra-processed, according to the most commonly used definition of ultra-processed foods, but yet they are not associated with risk and rather could be beneficial. I was recently at a Food and Drug Administration meeting where the FDA shared why they have no plans at this time to regulate ultra-processed foods. So they're not going to be have no immediate plans to put a warning label on foods, as this Newsweek toxic food article sort of encourages or suggests should be done. And the reasons they said that they weren't going to do this was, first of all, there's no consensus on the definition of what an ultra-processed food is. And if we can't define it, how is people in the public supposed to figure that out, or how are we to label foods if we don't know actually what is an ultra-processed food? Another is that there's just not enough scientific evidence yet indicating that all ultra-processed foods are bad for health. Nearly all of the research so far has been observational epidemiologic studies, which are beneficial for helpful in understanding things, but they're not the best for establishing causation. And there's only been 2 very small randomized trials. And so it's just not enough evidence right now to make this, a big recommendation that affects a lot of foods in the marketplace and that people eat. Another is that 80% of ultra-processed foods are high in nutrients known to increase risk, like added sugars and sodium. but some are low in these nutrients and contain nutrients for which adequate intake is encouraged. And I just gave some examples of some of those kinds of foods. And then finally, there's concern about, what the potential adverse consequences of regulations that limit the production and purchase of ultra-processed foods might be. That hasn't been very well looked at yet. The things that kind of come up as concerns are, one is that it could increase food costs because shelf life is apt to decrease when you remove some of these ingredients that are hallmarks of ultra-processed foods. And so that can be hard hitting, especially for lower income, those with lower household incomes who are trying to stretch their food dollar already. Another is that it would likely take more time to, prepare food at home if you're not relying on some of these foods that are ultra processed. And today, women still are the primary people responsible for food preparation in the home, and so this would hit them particularly hard with time costs. So that's ultra processed foods, why we're not quite there in making recommendations and doing regulatory work around it. So now I want to, and I also want one other potential unintended consequence, which I think we're already seeing in the marketplace, is that food manufacturers are now moving towards what they call clean labels, where they are removing ingredients that would classify them as ultra processed, but yet they haven't really addressed maybe the sodium content of the food or the added sugar content. They haven't reformulated to get rid of those nutrients we know we have good evidence we should be limiting intake of. And so these potato chips would not be considered ultra processed based on the most commonly used definition of ultra processed foods because they have moved towards this clean label. So those are some thoughts around ultra processed foods. Now I want to get into sharing just a couple public health success stories around nutrition, diet, and heart health. And the biggie is that the Food and Drug Administration banned the use of partially hydrogenated oils in the U.S. food marketplace. This ban took effect in 2020. And they banned partially hydrogenated oils because they are the source of man-made trans fats. And you've probably heard of trans fats. They are shown to be to lead to heart disease. And so this is remarkable because now there are no more man-made trans fats in any of the foods in our U.S. food supply. So this benefits all of us, and we don't even have to try. We don't have to read product labels and search and try and find that product that doesn't have trans fats. It's been taken care of for us by this ban put in place by the FDA. And I think that a lot of people don't know about this. I think it's one of those underappreciated or underknown, even by healthcare professionals. They don't necessarily know that this change has happened. And so I actually worked with a student a few years ago, Cecily Weber, to take a look at the margarines in the U.S. marketplace and whether they still contain trans fats. This is post the FDA ban, to just sort of confirm that there was regulatory compliance, that indeed there was no more trans fats in these products, and then to see kind of what they look like in comparison to butter for saturated fat, because maybe they reformulated the products so now they were just as high in saturated fat as butter. And what she found was that indeed the ban worked, that none of the margarines that we looked at contained trans fats or partially hydrogenated oils. And they also are lower in saturated fat than butter. So the way they reformulated was, didn't lead to a product as high in saturated fat as butter. So we did this because we wanted to confirm regulatory compliance. And then we also just wanted to publish something that would share the news that this great thing had happened. And we were excited to see one case where the study was actually used in policymaking in Iowa. In 2023, this state representative, Jeff Shipley, introduced legislation that would ban margarine in school meals because of its trans fat content, and butter would be used instead. And this Emily Piper from the Iowa Association of School Boards, she found our study and she cited it as saying that, there's not trans fat in margarine. And so we should be making this regulatory decision based on scientific, on science. And so we're glad we published this paper. And I just want to, share with your friends and family that this great thing has happened and they don't need to worry about trans fats on labels or anything like that anymore. All right. Another public health win is that the saturated fat content of our diets has gone down since the 1970s. And the 1970s is when there was first recommendations started around limiting saturated fat. And we think that this change has happened because partly getting the news out there, education, people have done the things that have been recommended, like choosing lower fat dairy and choosing leaner meats and those sorts of things. But also the food industry stepped up in this case. For example, most fast food restaurants switched from using frying oil that was high in saturated fat to using vegetable oils that were lower in saturated fat. I'm going to wrap up with one last, looking at my time, I think I've got a minute for one more thing. And a public health story that's in progress that you may hear about in the coming years, or maybe you've already heard about it. And that is around sodium. Americans consume way too much sodium. I'd said earlier, the recommendation is to consume no more than 2,300 milligrams per day. And you see in this graphic, and this is data from actually the Minneapolis-St. Paul metropolitan area from one of the studies we used to carry out here called the Minnesota Heart Survey. And you can see that over this decades period, sodium intake just stayed flat, well above recommended intake levels, no declines, despite the fact that the public health message has been out there for decades, encouraging people to limit the salt in their diet. And so one of the reasons that our public health messaging has not been successful is that most of the salt in our diet comes from packaged foods and restaurant foods that are high in sodium. And so telling people to, use less salt at the table or don't put so much salt in your food when you're preparing it is not very effective. And the CDC actually funded us to do a study where we identified the sources of sodium in the American diet. And this graphic shows that 71% of the sodium in our diet comes from outside sources, from packaged foods and from restaurant foods. Only about 5% is what we add at the table with our salt shaker, and only 6% of it is what we add in home food preparation. So we as individuals don't have very much control other than sorting through product packages at the supermarket and trying to find the lower sodium options. And in some cases, there's very few lower sodium options even within a product category like soups. So the FDA is considering changing salt and sodium containing compounds used as ingredients in foods from being on the generally recognized as safe list, which means when an ingredient is on the GRAS list, as it's called, a manufacturer can use as much of it in their products as they wish. If it's not on the GRAS list, then the FDA can regulate and say, wait, you can only put so much of this ingredient in a food product. And if they did that, they could say, well, within crackers, you can only put so much salt in crackers. And that could help lower the sodium content of our packaged foods and restaurant foods, which would benefit us all without having to worry about reading product labels to choose products lower in salt. So I'm going to wrap it up there, and thank you for your interest, and I'm looking forward to the question and answer period.
Great, thank you for that overview. Now it is my pleasure to bring in Junio DeBrito. Junia is an assistant professor in the Department of Family Medicine and Community Health at the University of Minnesota Medical School. Junia is a social behavioral epidemiologist and a trained dietitian. Her research focuses on investigating the interplay of structural and social determinants of health and health-related behaviors that contribute to obesity and cardiometabolic health disparities among children and families of racialized and other marginalized groups. Junia, can you discuss with us disparities in heart health and disease management, particularly in Minnesota, and talk about what we are doing at the University of Minnesota to promote heart health equity?
Thanks, Jeremy. It's so nice to see so many people here today. And Lisa, thank you so much for sharing those public health wins. Those are amazing. So today I'm gonna give you like a brief background. Oops. Can you hear me? Okay, I got a warning. So today I'm going to be covering some of the background of cardiovascular disease and then leading into some of the disparities that we see in heart health as well as in cardiovascular disease. And then I'm going to highlight a study that we are conducting right here in Minnesota. So as Daniel shared, heart disease is the leading cause of death in the United States. And there is a cluster of diseases that Daniel did an amazing job explaining. I just want to highlight that those diseases are highly prevalent. About 1 in every 5 deaths in the United States are related to heart disease. About 4 in every 5 cardiovascular disease deaths, they are due to stroke or heart attack. And about a third of heart diseases deaths, they are premature, meaning that they happen before the age of 70. And new projections by the American Heart Association Presidential Advisory that you see on this slide projects that this will become even worse and even more common within the next 30 years. And it's forecasted that about 61% of adults living in the United States by 2050 will have some type of a cardiovascular disease. And these trends they are projected to be worse among people identified as American Indian and Alaskan Native, Black and African American, Hispanic, Latino people, as well as multiracial individuals. And there are substantial geographic disparities in heart disease prevalence across the US. And you can see here in this map that heart disease prevalence are really, really high at the southern states. And we also see very significant disparities in terms of race, with non-Hispanic, Black, and African American people being disproportionately affected by death related to heart disease. And recognizing the importance of preventing heart disease, the American Heart Association developed the Life Essential Weight Framework. And that includes 4 key health behaviors and health metrics. For the behaviors, they include a healthy diet, a regular practice of physical activity, adequate sleep, as well as minimum to no exposure to smoking. And in terms of health factors, it includes maintenance of blood pressure, blood lipids, weight status, and blood sugar. And together, those measures, they provide this comprehensive guide to maintaining and improving cardiovascular health across the lifespan. And there are very important determinants of heart health, and those include psychological health as well as the social determinants of health. And they influence one's ability to choose a healthy lifestyle across the lifespan. And positive health characteristics include a practice of gratitude, optimism, and having a purpose in life. And some negative mental health characteristics include things like stress, symptoms of anxiety and depression, and so on. And in terms of the social determinants of health, those are conditions in which people are born, grow, live, worship, and age. And those conditions, they really are like the environments in which people are in, and that determine their potential for heart health preservation. So to walk you in an example, let's say someone has a higher income, higher educational attainment, a stable job, a stable housing, live close to a grocery store that sells healthful food items, and live close to a park where they can exercise. Those are all positive social determinants of health that are known to promote optimal cardiovascular or heart health. And as you can imagine, the opposite of that, meaning someone who lives in a low income household, has lower education attainment, has minimal access to parks and healthful grocery stores, they tend to have worse heart health. And this is really important to know because this disproportionately affects some groups of people who are living in this country. And though, namely, Black and African American groups are disproportionately affected, as well as other racially minoritized groups, people living, again, who have lower socioeconomic status, rural communities, people living with disabilities, and as well as people who have limited access to healthcare and other safe spaces for physical activity and access to a healthful grocery store nearby. And this matters because the persistent disparities that we see in heart health, it will make it really, really difficult to prevent the cardiovascular disease that I was talking at the beginning of the talk. And there are many challenges in addressing those health disparities. Past cohort studies, they have largely included people who are not disproportionately affected by those health disparities, predominantly male individuals, predominantly white populations. And we don't know much about these other populations who are being affected. So, and interventions that have come up throughout the years, they have largely ignored the role of the psychosocial factors as well as the social determinants of health and influence heart health. And one of the things that we can do moving forward to improve this scenario, especially for the groups who are being disproportionately affected, is to really have the involvement of the communities who are being affected into the studies and really tackle all the psychosocial, the social, the economic, and the structural barriers to heart health. And this brings me to my research. And one of the key aspects that I have been focusing on lately is on physical activity. And I won't go into detail because Daniel did such a wonderful job about all the amazing benefits that physical activity has across all ages. But we know that there are also significant disparities in terms of engagement in physical activity according to the public health recommendations. And we see that across the lifespan, people are just not exercising enough. And we see very significant disparities in terms of race. For example, we know that non-Hispanic, Black, and African American adults, they tend to have higher prevalence of physical inactivity compared to the white counterparts, as well as other racially minoritized groups like Hispanic, American Indian, and Alaskan Native. They tend to have higher prevalence of physical inactivity. And same goes for in terms of sex and age and sex and incomes in terms of disparities, where men are more likely to meet physical activity guidelines across all ages. And as their family incomes increases, they also tend to exercise more compared to those who don't have that income increase over time. And as I was explaining before, the disparities that I noted in cardiovascular disease, as well as physical activity engagement and heart health, they are largely shaped by the environment in which people are living. And those are social determinants that shape access to resources, opportunities that may impact the health behaviors and health factors that I showed you in terms of the life essential eight. And there is substantial amount of evidence that shows that inequitable distribution of resources across neighborhoods in the US, they largely exacerbate those disparities in physical activity, in heart health, and eventually cardiovascular disease. And in the statement put forth by the American Heart Association, it provided guidance on different opportunities to improve our understanding of the ways in which neighborhoods influence cardiovascular health and as well as the way that they drive disparities. And key thing about this model that you see on the slide is that this differential distribution happens at different levels, from the individual all the way to the structural levels. And one of the aspects of my research is focused on the neighborhood access to parks and green spaces. And my research is really driven and guided by the fact that green spaces and parks, they may lead to better cardiovascular health because they provide opportunities for physical activity. So it's really focusing on this primordial prevention of heart disease, in which we are really focusing on the social and environmental determinants with the goal of reducing the prevalence of cardiovascular disease later in life. And beyond the fact that parks also, they improve the social and emotional well-being of people, and they benefit children and adults. And a lot of the studies coming out, they have shown many benefits of being outside at a park, including reduction in stress, improving cognition, and also the benefits of reducing air pollution. And there are many evidence-based work that can guide studies that will advance cardiovascular health. And those can really be grounded in health equity principles to really improve the heart health of the population. And one of the things that we do is really building partnerships with the communities who are most affected by heart health disparities, and we work with the communities and listen to them to make sure that we move the needle in terms of improving heart health. And a lot of the work that we have been doing lately here in Minnesota, it's really thinking about how parks can be safe and how we can use culturally affirming approaches to increase physical activity for those who are disproportionately affected by heart health disparities. And really thinking that parks, those are really infrastructure portions of cities that serve as this determinant of health to promote our health. You might have seen that 99% of residents in Minnesota, they tend to live really close to a park, like less than a 10-minute walk. But again, not everybody has the same access, with communities of color and those living in lower income neighborhoods having less access to a nearby park. And all of that brings me to the research we are doing right here in Minnesota. And we have some folks on the call here, and this is a community engaged work we called Nature Uplift that was really designed to improve heart health for African American families in Minnesota. And we partner with the Three Rivers Park District, and our community engagement team is housed at the French Regional Park. And that's where our pilot intervention study happened. And it's a beautiful park. For those of you who are around the area, there is an amazing visitor center, playgrounds, and a lot of well-maintained paved and unpaved trails with those large trees and canopy covers. So it's really beautiful. And I don't expect any of you to read this, but part of doing a community engaged work is to really listen to what your community partners' needs are. And we engaged in several activities led by our amazing co-investigator, Heidi, where we were holding sessions to understand our community partners' needs, gather their perspectives on barriers to park use, and we co-develop ideas, right, to really align with their priorities and the cultural values of the communities that they serve. And another big portion of our work, community engaged work, was really to review the data that the park already had collected. And we really focused on themes that were coming out from qualitative and quantitative data. And we noticed that a lot of the African American families, they noted some barriers and interest in terms of engagement with the park. And in terms of barriers, they noted a limited cultural representation, meaning a lot of people leading the activities, they did not look like them. They have low awareness of park activities and some challenges in terms of understanding maps to engage the trails. But they also highlighted that they were excited to learn more about nature-based activities as well as learn more about hiking. And that's exactly what we did. We tackle all of it. So we really designed activities that were led by our amazing cultural liaisons. We developed this curriculum using the existing park activities. We installed trail signage to offer guidance on how to navigate the trails. Our partners did that, which was amazing. And we added this hiking component to our intervention. And here you see the basic design of our pilot trial. It was a 2-arm randomized design, and people that were randomized to the Nature Uplift arm, they engaged in 12 weeks of a nature-based curriculum that I will explain soon. And then the other group was randomized to the same curriculum plus an active component, which was the hiking components that the families highlighted that they were interested in doing. And as with any community engaged work, there is no such a thing as a usual care arm. So everybody got the benefits of doing the nature-based curriculum. But then one group got the active intervention, like the hiking. So we could increase the heart rate up and hopefully help the families meet the public health guidelines for physical activity. We were really focused on increasing physical activity for the families, but we were also tackling those psychological health that I explained before, because those are drivers of heart health. And we also measure other things like blood pressure, weight status, body composition, sleepy, and so on. And in terms of engagement with the park, we also asked several questions about, how frequently they visited the park, what kinds of activities they did at the park, and so forth. Results are coming up very soon, so stay tuned. And I just want to highlight that we recruited African-American Black parent and child dyads. And the child had to be aged 8 to 12 years old. And again, we wanted people that were not engaging in the recommended physical activity guidelines. So they were kind of at risk for that disparity that I explained in terms of heart health. And here, like I said, we had wonderful cultural liaisons that really did this amazing work with the families. Like Nicole, she developed the nature curriculum for the families, and then Velma, she was the one leading the hike for the family. So it was really this group activity that made all the difference for this intervention. And in terms of our Nature Uplift curriculum, you see some activities that we offered over 12 weeks. We had for 1 hour light intensity physical activity, meaning that your heart rate does not really get up. But they were doing like yoga, they were learning fishing, geocaching, and so on. And this was really carefully crafted by Nicole and our community partners to offer to the families. And we provided very detailed information for the family so that they knew exactly what was coming up when they showed up at the park, and as well as when they would receive their incentives. And in terms of the other arm, the hiking component that we added to the nature curriculum, families would spend 2 hours at the park for 60 minutes doing the nature-based activities and another 60 minutes on the hiking. And you can see like the path that we determined for the families to engage in. We had some elevation. It was like a moderate intensity hike with some unpaved terrain. And it was about like 1 hour that families took to complete the hike. And you see some of the trail signage that our partners included for the families. For the hiking group, we really encourage them to meet public health guidelines for physical activity. So we provide a lot of information for the adults and the children. And also safety was at the top of our mind. So we were really focused on making sure that they enjoy the hike, but also gave them like several ideas to keep safe when they were outdoors. Here's just an example of the calendar that we provide the families. Again, very detailed and fun. And also, our cultural liaisons were really attuned with the community needs. For example, you can see on the first week there, we didn't have intervention because, it was a holiday. So we were very attentive to holidays that could impact families' engagement in the trial. And here to finish up, we had some swag items to help the families feel confident and come into the park. Like we provide water bottles, like a bag to carry that, some fun stuff for the kids, some snacks on data collection days and other events. And then we also had some sunscreens that we got from the Women's Dermatological Society because they were outdoors doing the hiking. So sunscreen was important. And our cultural liaisons, they had like a first aid kit. Everybody was CPR certified. So it was a very well thought out project. And with that, I just want to highlight the amazing work of our study team. Community engaged work needs to have a very diverse group of people doing this work and passionate about this work. And I'm really grateful for the team that we had doing this work. And as well as our wonderful study partners. And without the funding, that would not be possible. So I also thank the Birch K-12 and the C2 Dream for funding this work. And I leave you with some pictures of our team at the park. So thank you.
Well, thank you very much, Junie, for sharing that very interesting work that you're doing, and it looks like a lot of fun as well. And thank you, everyone. We've been getting a lot of really good questions throughout the talk. And if for our listeners, if you still have questions, you can submit those still ongoing. But why don't we start with Daniel? We've had a lot of questions that were kind of relating to heart rate, and if there is a target heart rate that you should try to meet, or can you use heart rate to gauge if you're in a moderate or a vigorous level of activity?
Yeah, that's a great question. So heart rate is one of the good metrics to use to kind of gauge where your effort level is at. In general, when we're talking about kind of that moderate heart rate zone, we're sort of thinking like 50% max heart rate to around 70% max. And then in that more vigorous zone, kind of 70% to 85 your maximum heart rate. And if you don't know your maximum heart rate, you can estimate it by using the equation 220 minus your age. So if you're someone who's 50 years old, 220 minus 50 would be 170, and you can do your percentages based on that. Another good way to judge intensity is kind of your breathing effort. So moderate intensity, your breathing rate will be up. You'll still be able to speak in short sentences without having to take a breath in between, but you're not so strained where you can't talk. Whereas when you get into that more vigorous intensity, now you're probably only getting sort of one or two words out in between breaths. So the kind of talk test, as we call it, where you see how well you can speak based on breathing, is another really easy way to sort of check yourself while you're being active to figure out, are you in that moderate or vigorous intensity zones for exercise?
Great, thank you. Let's move to Lisa. There's there's a question about coconut oil, and I too, you hear a lot about tropical oils, and how would you kind of put those in your healthy oil spectrum? Because there's a lot of back and forth about that, I think, in the media.
Right. Well, in the dietary guidelines for Americans and the American Heart Association, both place them in sort of the bad fats that you should limit consumption of because coconut oil and palm oils are high in saturated fat. The there's been some thought that, well, maybe they're not as bad as other saturated fats because they are high in what's called medium chain triglycerides, which is a shorter chain fatty acid. And there's been some research looking at this. Findings are mixed, and there's not a really robust body of evidence and not enough to say, oh, they're off the hook. They're okay. They're okay for us. So that's kind of the science on it, where it stands today.
Thank you. Junia, so can you talk a little bit more about how stress can affect heart health? I think if if you ask anyone, how stressful are things, there's stresses at job, stresses with family. What is kind of an unhealthy stress, or is all stress unhealthy?
That's a great question. And not all stress is unhealthy, right? It's good that you get stressed out when you have fear, for example. So it's important that you are alert and attuned to that. But there are a lot of evidence in terms of how stress can from external environment can get under your skin to really affect how the health of your heart. So what do we think when we think about cardiovascular health? It's really trying to get people to minimize those stressors. And we know the stresses are many, right? So there are stresses with the job, with the child care, and so on. And how can people balance? That's the $1 million question, right? Because the environment that we live in, it's fast paced. Nobody has time for anything. It's really thinking about ways that we can work on around our lifestyle and incorporate on our daily lives to really minimize stress. And that can be through physical activity, having a healthful meal with your family, and finding things in joy on everyday life despite everything that is, might be going on people's lives. So just trying the best that we can to minimize it.
And would you say that it's fair to say that there's a correlation between some of the things you see in under-resourced neighborhoods, like low access to parks and stress levels? I mean, is does that play into it?
Yes, yeah, absolutely. And I feel like there is a lot of evidence that has been generated with more privileged communities. So we don't know as much about more like under-resourced communities, but we know that they tend to be disproportionately affected because that burden of stress is so enormous that tends to affect heart health even more negatively.
Thank you. I'm going to keep popcorning around to keep everyone on their toes. Daniel, there's some questions about that IMST device, about where one might find that. Is it covered by insurance?
Yeah, that's a great question. So these devices are commercially available. A lot of them are really marketed kind of for sports performance. So the idea was that they were these specific lung training devices that athletes could use to get better, faster, stronger. So the use of them for cardiovascular health is kind of repurposing an existing technology. So there's a bunch of companies out there that make devices that do inspiratory muscle strength training that provide resistance when you inhale. What I recommend people look for is a device that can sort of provide a high level of resistance, because the trade-off when you're doing 30 resisted breaths per day, as I talked about, is those 30 breaths have to be really hard. And some of the devices on the market just aren't up to snuff. They can't give you enough resistance to kind of do the training. So the units for resistance when we talk about respiratory exercise are centimeters of water. And I tell people if you're going to buy a device, make sure it can produce at least 100 centimeters water of resistance. The very cheapest devices aren't going to get close to that. But for probably around $70, $75, you can get a device that is able to go much higher intensity than that and can kind of fulfill the training. The other part of the question is, are they covered by insurance? And not yet. So the data on this intervention really come from a good number of studies now, but they're mostly small clinical trials done, over the period of 1 to 3 months. So it's still kind of ballooning out into those large clinical trials that need to be done before insurance companies will carry it. So that's the goal and where this research is headed, to kind of move it out of the laboratory and into the public health domain, but not yet covered by insurance.
You know about like health savings accounts?
I don't think so, but that's a good question.
Okay, thank you. Lisa, another oil question, this time about fish oil. So, this is pushed, I think, recently, but then maybe not recommended. Is there any value in taking fish oil supplements?
There is. The American Heart Association recommends, first of all, trying to get omega-3 fatty acids through your diet. And so that could be fatty fish such as salmon, sardines, herring, lake trout, and albacore tuna. There's also some foods like walnuts and flaxseed, soybean oil, canola oil that are rich in omega-3 fatty acids. But an alternative is to take a supplement, and they're recommending one that contains 2 grams of omega-3 fatty acids per day. So yeah, it remains important, but ideally you'd get it through your diet.
Okay, thank you. We'll stick with the oil theme. Junia, I don't think this was covered in your talk, but to kind of touch on your dietitian background as well. Uh, an older remedy maybe was for healthy was drinking olive oil and apple cider vinegar, um, having a daily cocktail of that. Is that something that has any evidence to support at this time?
Uh, there is minimal evidence in terms of the um, what is the second part that you said? You said olive oil and
Apple
apple
cider
cider.
vinegar, and olive
In
oil.
terms of the apple cider vinegar, I recall seeing very small studies that people tend to drink before a meal, and it tends to improve digestion. But we don't know that at the population level. And Lisa, you might correct me if I'm wrong, but I haven't seen that at large scale. But in terms of olive oil is part of a healthy Mediterranean diet, and it's highly encouraged daily consumption of oil. And I'm a fan of olive oil. I add at my salad, and it's amazing. So highly recommended, and it's backed up by studies.
Right. One of the biggest dietary studies that we have for heart health was very high in olive oil, actually, in both arms. So yeah,
Yeah, cool.
thank you. Um, Back to Daniel. So one thing I didn't hear mentioned was yoga, and there's some questions about where that might fit in, what category that might go in, aerobic, muscle strengthening. Where would you place that, and how would you kind of rank it in terms of benefit?
Yeah, so there's lots of different styles of yoga, so it sort of depends on how you're performing it. If it is something that is maybe more physically taxing, it could have a muscle strengthening or aerobic component. I think in general, when we just classify physical activities, we think of most forms of yoga as maybe being low intensity and not really meeting the moderate or vigorous intensity or kind of filling that strength training bucket. But there are types of yoga that, could probably fit the strength training if you're doing a lot of challenging holds that produce a lot of muscle tension. I think, if you finish and you're tired, then it was a workout, and that means it was leading towards your activity. If you aren't fatigued at all at the end, then it probably was a low intensity activity that didn't contribute to meeting those physical activity guidelines. But even if it's low intensity yoga, there's still a lot of benefits associated with yoga outside of, when we think about having a higher heart rate with aerobic exercise or kind of having those muscle strengthening activities. So it's certainly still a good thing to do. It can impact our sympathetic nervous system, which also contributes to cardiovascular disease risk. So, even if we can't say for certain where yoga will fall in on the scheme of things, it's still a great thing to do to improve your heart health.
What about combining, the sauna world and the yoga world and the hot yoga? Any incremental benefit there?
Yeah, so probably. So hot yoga, it will get your heart rate going because your body is trying to dissipate heat. And your response to that is your heart to work harder to pump blood to your skin to try to give heat off to the environment. And that's similar to that heat therapy sauna research I talked about, where that's really stimulating the cardiovascular system like it would be stimulated if you were going for a walk or a run. So I think hot yoga is probably one of those types of yoga that will probably fit more into the moderate intensity aerobic exercise realm if you're getting your heart rate up into that 50% sort of max zone or higher, which is, fairly easy to do if you're combining being exposed to heat and even low level physical activity.
Oh, great, thanks. Lisa, a question about salt. And there's a lot of options for salt that you can buy now. Sea salt, Himalayan salt, uh, other salts, I don't know. But there are many different options. I do know that. Is there anything that's better than the normal quote unquote, table salt?
I think there can be taste differences. Maybe you like the flavor of Himalayan salt more. But from a nutritional perspective, it has a little bit more of some minerals in it, but a very, very tiny bit that really is not a meaningful amount. So I would not choose a certain kind of salt for health benefit reasons. Iodized salt, I mean, some of those, like Himalayan salt, is not iodized, and iodine is important. Iodine is important to us, especially for women of childbearing age, to get enough iodine. So I worry a little bit about moving towards some of those salts if they're not iodized.
Hmm.
There's salt substitutes out there, like potassium chloride salt substitutes, and those can be great because they're helping you lower that sodium in your diet. And most Americans don't get enough potassium in the diet, and so then it boosts your potassium intake. So I'd suggest giving that a try. And there's even some that are a blend of potassium chloride and sodium chloride, which is just salt, combined together. So it's a mixture. So it's a little, more might taste better to you, but yet you're still making an incremental cut in the sodium in your salt.
Yeah, thank you for pointing out the potassium-based salt. Is that something that's easy to find in supermarkets, or how is that labeled?
It is. It's easy to find. It's usually labeled as a salt substitute. And you'll see that some manufacturers have started adding it to their products, those who are trying to lower the sodium in their products, which some manufacturers are. And it can look scary because it says potassium chloride, and people are like, "Ooh, that's a scary ingredient. I don't know what that is." Well, if we called salt sodium chloride, which is what it is, it might look scary too. So the FDA has approved it being called um, potassium salt. So you may see it on product labels as potassium salt or sodium or potassium chloride. So don't be afraid of it if you see it in the ingredient statement. It's your friend.
Thank you. Junia, this is a question that is near and dear to me as I have little kids. Is there any studies about all the screens that kids are exposed to these days and how that might affect heart health?
Yeah, that's an excellent question. There are, and kids, they're largely exposed to screens these days. It's very different than if you look at 10, 20 years ago. And that really impacts the amount of sedentary time that kids engage in, and that could negatively affect heart health in the long term. And another consequence of excessive screen time, and when we say excessive, like for very young kids, no screen at all, and then as kids grow older, 2 hours max of screen time. Because when kids are exposed to so much screen time early on, they develop that addictive behavior over time, and that it's really hard to make them, for example, change that behavior for physical activity, right? That's what they should be engaged in every day, have that full hour of playtime, so they keep that habit as they grow older. But when kids are exposed to so much screen time, that takes away that health habit, and it's swapped by an unhealthy habit. And of course, we have, homework and so on, but we are talking more like that lounging, just like watching excessive amounts of screen time that can really negatively impact heart health.
Right. There's so many hours in the day, and the question is, what is it replacing, right?
Yeah,
And often it's
exactly.
maybe more healthy behavior.
Yeah.
Thank you. Daniel, pickleball is sweeping the nation. How would you kind of rank that in terms of activity level?
Yeah, that's another tricky one, kind of like yoga, because it depends on how you play. If you're a novice and you're playing against someone who's making you move all around the court, then that could be vigorous activity. But if you're playing doubles and are relatively stationary, then it's probably more moderate activity. Um, but I think in general, we think of pickleball as being more in the moderate range. But you kind of, you're asking me a lot of questions about how do we judge intensity and what, is the intensity of this type of exercise. And, one thing I want to reiterate to people is the best type of physical activity is the one you'll do. And we don't necessarily think there's very different impacts on heart health if you're doing moderate intensity versus vigorous intensity exercise. The main difference is just how much you need to do a week, where you need a little bit less exercise if you're doing vigorous. Um, but really, if you're getting out there, being active, getting your heart rate up, that's the most important thing, and not, who am I exactly in the vigorous range or am I exactly in the moderate range? You know, those are kind of somewhat made up and arbitrary for guidelines, but there's not really a difference between exercising at 65% of your max heart rate, which would be moderate, versus 75% of your max heart rate, which would be vigorous. So, yeah, find physical activity you think is fun that gets your heart rate up, gets you breathing harder, and do a lot of that.
Lisa, there was a question about, let's see here. If there's an alternative to salmon, and maybe the question would be maybe some other healthy fats, other sources, either from seafood or other non-seafood sources.
Right, right. So this is, the salmon's this great source of omega-3 fatty acids. And the other fish, and especially with an eye towards Minnesota, um, now I lost my notes. I actually wrote down the different kinds of fish and that's it. Um, so lake trout is actually a good source of omega-3 fatty acids. And then albacore tuna, if looking for a lower price, shelf stable source, buying some of the canned albacore tuna would be a good choice. And then walnuts are a good source. So if you can build those into your diet. So those are the ideas I have.
Great, thank you. Junia, you looked at ways to make parks more welcoming. Were there any really more impactful methods? I think this is something that, people could take home to their communities and their own parks to help increase, activity and access to everyone.
Yeah, so one of the things that we noticed when we started reading and the data that the park collected, and with the community engagement sessions that we had with, even before like writing the grant that supported our work, we noticed that a big barrier for engagement and for people feeling safe at a park is whether they have people that look like them. And as you can imagine, there are a lot of racially minoritized communities. They are not well represented anywhere in Minnesota, right? So they would go to the park and they might have experience of harassment or discrimination. And that makes it really hard for people to feel safe in that space. So they would just not come back to the park, right? So one of the things that we were really keen on and dedicated committed to fixing with our community partners was really to add representation at the park. So we had a very diverse team of people, of partners, of study staff, and as well as people that really like the co-development of the intervention was really with people that looked like the community that we recruited. So that was a key thing that we worked on, and we have some qualitative data that we collected. We added some open-ended questions when participants answered the survey, and we asked a specific question about having that person leading the hiking or having that person like Nicole and Velma leading the intervention activities, and it was overwhelmingly positive. And I can't wait to report them soon to the community, to this type of audience, because it really makes a difference for people engaging at the park. They need to feel seen and they need to feel represented, and that contributes for their feeling of safety at that space.
Thank you. Quickly, Daniel, any safety concerns with sauna, such as high blood pressure or varicose veins, or any health issues where people should avoid the sauna?
Yeah, well, so the big health issue is related directly to heat exposure. There's acute risks of getting too hot and having heat stroke. So you definitely want to make sure that you're being safe and not staying in the sauna or in a hot tub for too long, or you can have those sort of negative effects. Otherwise, it seems fairly safe, but everyone's health profile is different. So definitely check with your doctor. But if someone's able to do cardiac rehab where they're walking on a treadmill, they're probably also able to do sauna.
I think that's a very good point. Well, thank you again to all of our panelists today for your time and for sharing all of your insights and your work and your research that you've done. And we'd also like to thank all of you, our participants in the Mini Medical School, for joining us today. We do hope to see you again next week for the second Mini Medical School session on the heart and the body, interconnected health. This will be at the same time next Wednesday, and we have an amazing group of experts that will discuss the crucial role the heart plays in the health of multiple body systems. Thank you again, and good evening.